So I think this is a really, as I was thinking about this topic, I said, why do they want me to talk about neurogenic bladder? But the reason is that we've got new guidelines and we're changing the way that we're doing it. And I think it's actually a really timely discussion. So thank you for suggesting this topic. Again, no disclosures. Briefly going to talk about epidemiology, pathophysiology, evaluation management, and long-term follow-up. And I just want to put a giant sign up that says, we are going to change the way you practice management of the neurogenic bladder patients after this talk. So we look at spinal cord injury a lot because spinal cord is very defined. You know they've got an injury and they have bladder dysfunction. So this is a patient population that you're maybe going to get more information about. So in the United States, we have over 270,000 spinal cord injury patients. However, if you think about neurogenic bladder, we've got a whole lot more than that, exponentially more. So a real common question that I get is, what is neurogenic bladder? People are very confused about it, and I'm a very simple person. So I break that down. All it is you have a neurologic diagnosis or nerve injury, and you have bladder symptoms. That's neurogenic bladder in a nutshell. It doesn't tell you what that means for their symptoms, but that's how I describe it to patients. So you'll actually find a lot of your patients may qualify for that diagnosis. Briefly, for any learners in the room, let's talk about some voiding physiology. I know it's really boring, but it's very important. So I like to think of the bladder in the filling phase and the emptying phase. When to fill the bladder, you basically have to have no bladder squeeze. It's got to be nice and calm. You have to have stretch, and then you have to have a closed outlet so you can't be leaking as you're filling. Normal emptying requires that you have relaxation of the opening, the sphincter, and then a contraction of the bladder to push it out. And this requires an interaction of the SNS and the PNS to actually occur. Now, an important topic that we're going to briefly talk about is spinal shock. And I think everyone knows for the tests, spinal shock, it's important. It has a very different symptomatology than what they're going to have long term. It is the acute phase of a spinal cord injury. Importantly, it lasts 6 to 12 weeks, sometimes even more. The reason I bring this up is if you start an evaluation too soon, you're not going to get the appropriate information for the patients. So you have to wait until their bladder symptoms kind of even out a little bit. And these patients almost always have urinary retention during that acute setting. So that's when you're in the hospital, you're consulted about urinary retention. That's why, and that's why it can get better. So I always counsel patients that their bladder symptoms are going to change. And you'll start to see the change when they start voiding again, or maybe they have the return of the bulbocavernosus reflex. I hope you all are checking for that. That is an important part of the exam. So that's how you know it's resolving. I like this diagram here because it tells you what to expect based on the level of the injury. So if you're talking about lesions that are in the brain, you're going to have a very characteristic appearance. They're going to have bladder contractions. They may have areflexia, so they can't coordinate and empty necessarily. They may have spontaneous incontinence from that bladder or detrusor overactivity, but they're really at very low risk for any upper tract deterioration. And that's what we're going to keep talking about, is what patients are going to have a problem if you ignore their injury. Then when you're talking about basically the T6 through the S2 range, this is the danger zone. This is where you can have a lot of bad problems. So these are patients that may have a hyperreflexic bladder, so the bladder is squeezing, but they may also not be able to relax that sphincter. Detrusor external sphincter dyssynergia. That's when you're going to have it. Now, I also think that the sacral lesions are a little bit concerning. They're the spina bifida patients. They're the patients that have had an APR with the colorectal team. These are the patients that may have an acontractile bladder, and they may actually have compliance changes. So they may have pressure going up to the upper tracts. So this is also a pretty nice slide, and it talks about the different diagnoses and where they're going to land in the spinal cord or the brain or the sacrum. And I think this is a nice review when you think about basically neurogenic bladder. So I have some urodynamics because I love urodynamics, so I'm putting them up here for you. If you have someone that has a brain nerve issue, you're going to see a lot of that detrusor overactivity. That's what their urodynamics are going to look like. They may or may not have urge with it. When you think of the suprasacral lesions, you're going to have a urodynamics that looks more like this. So you will still potentially have a bladder squeeze or detrusor overactivity, but you're going to have activation of that external sphincter. You're going to see that EMG spiking when they're trying to void. And this is actually how you diagnose it the best. This is a video urodynamics study. So you can basically see everything narrows, it's ballooned proximally, it narrows at the sphincter that fails to relax. And that's what it looks like. Sacral lesions, this is what the urodynamics look like when it's not a good thing. So you can see when you're looking at that detrusor line, that green line that's in the middle, it's slowly going up. It's telling us the pressures in the bladder are going up and up and then up and up. And this is where you have problems when you see that compliance change. So diabetes in the States, this is a huge problem. And we see a lot of neurogenic bladder patients with this diagnosis. The problem is it's insidious, meaning you don't know at first and it slowly changes symptoms over time. So after several years to decades, they may develop symptoms. And there's some thought that they get demyelination, they get degeneration, but what you tend to find is they don't fill their bladder. They've got huge bladders and they don't have sensation. They can't squeeze, so they can't empty. And then they may get some detrusor overactivity or bladder squeeze, but it's not coordinated, so it doesn't help them empty. These are tough patients because they've been non-compliant with their diabetes medicines. How am I going to get them compliant with their bladder? But it's nice to have a slide about it. Pelvic plexus injury happens all the time. If you look at the rate, so you can see for hysterectomies, it can be up to 80% of female patients if you have a radical hysterectomy. I don't think they're getting talked about their bladder issues at the time of their hysterectomy, but that's what's going to come to your office. Why do I have these symptoms? What's going on? This is what's going to happen to them potentially. Multiple system atrophy. This is a really tough patient population, which is why I'm bringing it up. Not only do they have detrusor overactivity, their symptoms get rapidly worse, and it's really challenging to deal with because they have a completely incompetent outlet. They have terrible stress incontinence. These patients make me probably the saddest in my practice, and they're very difficult to help because they're losing the ability to catheterize or do anything. So they kind of have to live with their incontinence. For everybody that does urodynamics, you need to know about autonomic dysreflexia, very important issue. And basically, it's going to happen in your patients with a lesion with T6 or higher spinal cord injury. Even the incompletes can have it. So you have to be really have a high index of suspicion that this may occur, and you have to know how to manage it. And really, it's take the catheter out, drain the bladder, and make sure you have some calcium channel blockers that you can give them. So we only do urodynamics on the days where maybe myself and Dr. Jamie Wright are there that we can administer those medicines if needed. Now, I want to highlight the AUA guidelines. I already saw that you brought these up, and I actually think these guidelines are really great, and they give us a lot of guidance that we didn't have before on how to manage these patients. Basically, it tells you when you have autonomic dysreflexia, you got to monitor them, and I'm sure you're all doing that, and you need to terminate the study and do the tricks to decompress the bladder. Now, when we think about evaluation and treatment of neurogenic bladder patients, we really need to understand what the goals are. And I think in my mind, the most important aspect is that I preserve their upper tracts. I make sure that we're not ignoring something that could result in renal failure. But other things, you want to prevent urinary tract infections because sepsis can be fatal for these patients. And improving quality of life is also important, but I have to admit that it's maybe not at the top of my list. Now, previously, spinal cord patients used to die from urinary tract infections. So we have really changed how we manage these patients, and they're living a lot longer and they have increased lifespan. But what that means for all of us is that we need to constantly be thinking about how to manage them and treat them because their symptoms may worsen and things may change over time. Okay, so this is the really important seminal study that talks about the bladder pressures and what's safe and not safe. So this is off of from McGuire. Basically, he demonstrated that patients with detrusor pressures, meaning their compliance changed, they got up to 40 centimeters of water, they were the ones that were at risk for upper tract deterioration. So when you're thinking about urodynamics, you're looking for this, the compliance change. And it's really significant. We actually can't do a study anymore because we saw how terrible the renal deterioration is. So I don't know what that exact pressure cutoff is where you're going to prevent upper tract deterioration. But this is where the study comes from. And so this right here is just that urodynamic tracing. If you look at that green line, you can see that green line's flat. And then as the bladder's starting to fill, and I think it's actually relatively low volume, maybe at about 150 or so, that pressure starts going up and going up and going up. This is a poorly compliant bladder, and that's what the tracing looks like. And that is the detrusor leak point pressure of 60 centimeters. So that's when that patient actually leaks, is at that pressure of 60 centimeters of water. So that's what we call the detrusor leak point pressure. So what's the workup of these patients? I talked about why it's important. Well, what do? Well, the initial workup's pretty straightforward. You always take an exam, a history, you do a physical exam, you get labs, upper tract, lower tract evaluation, or do you? So these are some history questions. Basically, you're getting at what are their symptoms, how much do they leak, can they move their hands, can they do catheterization. You also want to know a couple of important things. Do they have blood in the urine? Have they had a history of surgeries? And you want to get all their previous records. I think that's a nice overview of some of the questions to ask. Your physical exam, I don't wear a stethoscope anymore, so I'm not going to tell you about a lung exam, but usually you're focused on the abdomen and then the pelvic exam. Specifically, your neuro exam includes an understanding of their cognition, how they get around, how they move, how their hands work. If you have someone with spinal cord injury, this is a really great tool to utilize that can help you understand their neurologic injury. You want to test their refluxes. You want to see if they're in spinal shock. Do they have the bulbar cavernosus reflex? And then PVR and then a rectal exam, basically looking for tone. That's the whole neuro exam, by the way. But the important bit is, what do we do in our evaluation? How do we go beyond that exam? Well, we're actually dividing it into low risk and then undetermined risk. Okay, so this is a different idea. We're going to treat patients with neurogenic bladder differently based on what they have. So in an initial evaluation, all patients need to have a history, physical, and a UA. That's basically it. And then if you have someone that's voiding, you're going to want to get a post-void residual just to make sure that they are emptying. Right? You do not need to get upper tract imaging. Okay? That's what we used to do all of the time. So if you have a patient that is in a low risk category, you don't need to be getting ultrasounds anymore. I mean, that's a little, or renal function tests or urodynamics. Wow, let that set in. What does that mean for us? And then also cystoscopy. So they just took away everything that I used to do for my neurogenic bladder patients, and I don't do that anymore. And I think that's thoughtful. We're thinking about cost effectiveness, utilization of healthcare, really trying to spend our healthcare dollars well. But this is definitely a change. But it's different for the different risks, right? So this is the initial evaluation up at the top. This is all taken from the AUA guidelines. But when you look at the low risk, see who's included in that. That's a huge volume of our patient population, right? Patients with strokes, patients with Parkinson's, brain tumors, traumatic brain injury, cerebral palsy. I'm not going to have to do any of those workups on those patients, right? And then surveillance. I don't have to do it. Okay, this is just, it's mind-blowing, right? We're changing how we look at these patients. But it's probably better for them, right? They don't need to come to the urologist every year. They don't need to have testing that's unindicated. Unknown risk, that falls in a different group. And when you look at moderate risk and high risk, that's where you're going to do your routine evaluations. You're going to do your history and physical. You're going to be doing renal function tests, so just blood work, and you're going to be doing an ultrasound. High risk, you're going to do that at least annually. Moderate risk, every couple of years. So that doesn't change too much, but what really changes is the lower risk patient. So I would highly recommend reading the guidelines. I found them very informative. But when you have patients that have impaired storage, those are your high-risk patients, and you really need to be evaluating them. Another group that you need to think about is someone that's had a reconstructive surgery. They've taken the bowel and placed it on the bladder. You need to be doing more of a workup with them, and that includes a BMP or a basic metabolic panel, and you also need to get upper tract imaging because this is a different patient population group. Okay, and then the only time you're going to do cystoscopy, gross hematuria, or recurrent UTIs that you can't get under control with other methods. So those are who gets your cystos. Now let's talk a little bit about urinary tract infections. They're telling us not to get urine cultures anymore when we follow up these patients. And we know why, because they're all colonized with bacteria. I'm glad they said that. But if you do have symptoms, you need to not just get a urine test, you need to also get a urine culture. So you can't just get a UA, you need to get a culture in these patients. So we treat them appropriately with the right antibiotic. And then if you have someone that's not responding to antibiotic therapy, you may want to consider upper tract imaging or cystoscopy. Okay, so again, this is kind of interesting. It's changing the paradigm of how we manage these patients. So let's go on to the other things. Urodynamics. If you have someone with recurrent UTIs, you've done the upper tract imaging, you can't figure out why, that's when you can use urodynamic studies. But they really don't want you to use daily prophylaxis. I really like this one. We should not be using daily prophylaxis. It's different than PEDS. PEDS is different. But in the adult world, we really need to think before we give someone a daily suppressive antibiotic. And the AUA says that. Now, this is going to talk a little bit about treatment. And what I really like about this slide is we're thinking about the patient more than just medicines. They're changing how we think about these patients. We can do pelvic floor physical therapy for them. That was something previously we really didn't engage. We can also use beta-3 agonists. That wasn't in our armamentarium before. And then alpha blockers, it's in our guidelines. We can use that in neurogenic bladder patients. That wasn't something that we kind of said, maybe it'll work, maybe not, but they're saying, why not try that? And then in patients with intermittent catheterization, you really want to recommend that over an indwelling catheter, which we all agree with. Indwelling catheters are bad, but they're also pushing us to place suprapubic tubes, which I also think is a great move in the right direction. So another thing that I'm going to talk about briefly is bladder installations. I'm a big fan of bladder irrigations and bladder installations because this is a great way to treat these low-grade infections that are causing symptoms without giving them systemic antibiotics. So I think that's great that we have that. Hey, tell them they don't have to take cranberry. AUA says that we don't need to do cranberry, and it doesn't work. So now you can tell your patients that it doesn't work and not feel badly about it because they say it's okay. And then here we're just highlighting Botox. That's really one of the go-tos that can help with some of these UTI situations as well. So intravesical gentamicin, do you all use that here at all? It's great. Yeah, I see the PEDS team smiling and nodding their head. This is a great therapy. So for someone who's putting a catheter into the bladder, you basically put 60 cc's in at the end of the day at nighttime and you let it dwell. And then they pee it out in the morning. You put, you know, if it's a treatment, meaning that you're going to treat a UTI, you can use this too. It's not just for prophylaxis. So you can give it in the morning and then in the evening for treatment. You can have them on low dose once a day and they're not absorbing this and this is working. So I think intravesical gentamicin is a great option for your difficult patients. And if they're catheterizing, just teach them how to use a cath tip syringe and inject the solution. So this is a really nice algorithm. Ann Cameron, who is just absolutely wonderful. She was on the guidelines panel as well. This is a great algorithm to think about how to manage these patients. It talks about utilizing alpha blockers, antimuscarinics, beta-3 agonists. So if anyone wants to take a picture or write down this, I think it's a great algorithm for non-surgical management. Now, we all know a lot of these patients have detrusor overactivity, and we already know what these treatments are. We already heard about it today. So you know we have antimuscarinics, lots of side effects though. Beta-3 agonists, I think they're great, but in the States they're not covered well, and I have a lot of issues with that. Botox is one of my mainstays for my neurogenic bladder patients and really does work. This study proves it, many studies afterwards. We use 200 units, so it's not like the idiopathic 100 units. We're using 200 units. And that's what we start with. They are at high risk of urinary retention. So you're talking a third if they already aren't in retention. Another good thing about Botox is it may improve compliance. So patients that have that green line that's going up, this may change their compliance. And I know in the PEDS world, they use this for compliance issues all the time. And then you can use Botox in the sphincter. So that's something that some people try. I've tried, it doesn't work really great. So, but hey, you can definitely try it and it's pretty safe and it's effective. So when we talk about treatment, again, I want to highlight that our neurogenic bladder population is now being treated more like regular people. We can offer them all of the second line therapies. We can also offer them All of the third line therapies, isn't that amazing? We can now use sacral neuromodulation for patients that have nerve issues that affect their bladder. That was something that we were not able to do probably as easily as we are now. Now I have to convince the insurance companies to pay for it when they've got that neurologic diagnosis, but it's a great therapy. PTNS has been studied in this patient population, and you can see that patients respond well to it. There's low risks of side effects, and if they're able to go, 90% can have a response to initial treatment. And think about this, these patients have been suffering for prolonged periods of time. We need to give them some relief besides Botox and the antimuscarinics. Sacral neuromodulation, like I told you, basically they did a meta-analysis. They said they couldn't make any conclusions, and really it's off-label usage. But more and more literature is showing us that this may be a very good option for appropriately selected patients. The difference is we're not going to regenerate their nerves, but we may modify the nerves to prevent worsening of their neurogenic bladder. And that's kind of the evolution of research now, is to think about it that way. So it's very exciting. Now, you all know there are a lot of invasive surgical options for these patients, and you want to consider them when you've done all of the conservative measures. Now you have more you can offer your patients. You can treat them with everything that's in your armamentarium. But in patients that have elevated pressures, you're going to be more proactive. These are some of the things that we've talked about in the past that you all are aware of. You can do a sphincterotomy in your male patient with a detrusor external sphincter dyssynergia. Doesn't work well. It's really bloody. Then they're completely incontinent, and they're using condom catheters basically to drain their bladder. Conduits can work well with appropriate selection. The discussion of robotic versus open in the neurogenic bladder patient, robotic is just as good, if not maybe a little better. They go home a little bit sooner. So we used to think, well, we can't really use robotic surgery for these patients. That's not true. And then you have continent diversions. This is another good algorithm. So this is from the group in Minnesota. I think it's a really nice overview when you're thinking about surgical options for patients that have failed some of our second and third line therapies. So a little bit more about continent diversions. I think this room knows that you got to counsel and select your patients well. You don't want to be doing a giant surgery if they're not going to be compliant with what's required of them, and we know that can happen. And if you have someone with dementia, someone that's older, these aren't good options, and they really have to be compliant with catheterization. Briefly about outlet procedures, and these are something that I really appreciate. The guidelines also tell us we can do everything for stress incontinence in our neurogenic bladder patients as we do for our non-neurogenic bladder patients, which I think is amazing. The additional option of bladder neck closure is something I do in my practice routinely because they have a suprapubic tube, and then you stop their incontinence and they're managed basically with their suprapubic tube. Very happy with that. Artificial GU sphincter in this patient population, 100% continence at 5 years. I mean, we should be offering them the same things that we offer our other patients. Now, one thing you do need to watch out for, nerve issues affecting the bladder, you need to make sure that bladder pressure stays low. So the pediatrics team is going to tell you that's why you don't want to close off the outlet. You want them to have a pop-off valve so that if that pressure's high, it comes out the urethra and it doesn't go up to the kidneys. So this is one caveat to the idea of stress incontinence procedures. Now, really, what does this mean for our patients? I've been talking about what I'm concerned about, but we really also need to be thinking about what our patients are concerned about. Are we making their quality of life better? And the problem with patients that have spinal cord injury and neurogenic bladder, their symptoms may change over time. Their life changes over time. What they're able to do changes over time. So I would argue with the guidelines saying they don't need follow-up, they may need some sort of follow-up, because if their symptoms change or they lose dexterity and can't catheterize, you're changing your plan and your program. So they did do a survey, and this was in one of the internal medicine journals. They looked at 700 spinal cord injury patients, and they looked at what procedures were most satisfying for patients. And you can see Botox was well received. Augmentation, I'd say they probably had a good counseling session though. And then continent cystotomy. So they're doing continent procedures and it's well received. Fair satisfaction with the conduit. Again, we do that a lot in the States. We do a lot of conduits for neurogenic bladder. Slings, AUSs, but patients were not satisfied with intermittent cath long term or cystotomy or urethral catheter. I believe the urethral catheter one, but this changes our thought process a little bit. We need to really understand what our patients want. Now, one of the big questions we get is, do we do surveillance on our bladder augment patients? So when do you do cystos on your patients that have bladder augments or you have catheterizable channels? Really, unless you're maybe 15 years out or more, you shouldn't routinely be doing it, which again is a change in what we've usually done for our follow-up. So I'm almost done. I thank you for bearing with me, but I think that this talk has highlighted some really significant, I think, forward-thinking changes in the way we manage neurogenic bladder. We really need to think about these patients' risks and then determine follow-up based on that. I'm really excited about the potential of neuromodulation in this patient population to see if we can reduce the negative impacts of their neurologic diagnosis and improve their quality of life. But also I think we need to, as urologists and surgeons and providers, be thinking about quality of life on a longitudinal scale, knowing it's going to change from year to year, decade to decade, and needs to be reevaluated. So I'm happy to take any questions.